Thank you, Dr. Salke, and I would like to thank the SAGES folks and Dr. Salke in particular for inviting me out here today, and an hola to our friends down south who I hope are still connected to us. And I do have some disclosures to report. I do a little bit of speaking and a little bit of consultancy work to some of these companies who do make some medications that are related to the treatment of ulcerative colitis. And I'm happy to talk to you about the treatment of ulcerative colitis today, a bit of a hodgepodge of different slides from different sources, so when the backgrounds change, it'll sort of help stimulate you and wake you up in case you were at the tables all night last night and the night before and anticipating doing it tonight. I'm going to have a brief focus, or a particular focus for this largely surgical audience on where we break down and where medical therapy really doesn't get the job done, sometimes for reasons beyond our control, and sometimes really based on some patient-related things. So the goals of therapy for ulcerative colitis, as they are for just about any chronic inflammatory or any chronic illness at all, is to induce remission, maintain that remission, prevent complications of disease, and prevent complications of therapy as well, all with the goal, the combined goal, of maintaining and supporting as high a quality of life as we can get for our patients. Punishments fit crimes, and it's always important to point out that therapy of ulcerative colitis really needs to be directed at the type of ulcerative colitis that patients have. And for patients with low left-sided disease, just proctosigmoiditis, that therapy, of course, is really much more directed at topical therapy versus the systemic or oral therapy, even though it's a form of topical therapy. When they have more proximal and more extensive disease. ACG treatment guidelines have us really treating mild and moderate disease with mesalamine-based or aminosalicylate-based products. These are typically found in a number of different preparations, sometimes with a diazo bond, and that's the historically important sulfasalazine and now balsalazide. As well, and then there are all sorts of different oral preparations of mesalamine with different coatings and the like to generate more distal release. These really all came into being as a function of the failure of sulfasalazine for so many patients due to their intolerance to it. That's really dose-related. I've got a slide on that coming up. We treat orally, usually almost always when we can, even when our patients really do just have proctitis. For the simple reason that so many patients, particularly in this disease where patients are quite young, really don't adhere to our recommendations for rectal therapy. It's really tough to convince 20-year-olds that they need to be maintained on rectal therapy all the time. And so we do reach for the orals quite often, though probably just for the treatment of proctitis. Simple rectal suppositories alone are good enough. This is actually a bit of an antiquated slide, even though it's got the reference from 2004. There no longer exists, in the U.S. at least, a 500 milligram mesalamine suppository. They only come in a gram, which is probably better because we get away with just once nightly as opposed to the BID. And we do use topical steroid foams and enemas as well in appropriate situations. Sulfasalazine really is the world beater here. Nothing has defeated sulfasalazine, which was really brought to bear in treatment of this illness now almost 40, 50 years ago. And response is excellent. It is dose-related, but unfortunately so is toxicity. And so as you move up in dose, you move up in toxicity. This is a terrifically cheap medication relative to the others, but unfortunately, ultimately, patients really do develop meaningful intolerance when we start to get them into the 2, 3, and higher gram range per day. So it's really limited in that result. And so along comes some studies in the 1960s that quite clearly demonstrated that it was the mesalamine component, not the sulfa component of the sulfasalazine molecule that represented the reason for the success of sulfasalazine. And the big problem there was if you just gave a plain old mesalamine pill, too much of it would get absorbed and doesn't really get to the colon and therefore can't do its thing. And so the challenge to the pharmaceutical engineers out there was to figure out a way to get mesalamine to the colon. And this can be done in a number of different ways. Mesalamine has been demonstrated to be effective treatment with pretty good adherence, though I have a slide on that coming up. It's terrific for both the induction of remission as well as its maintenance. and can be used very safely. Very, very good side effect profile that appear not to be dose-related, and efficacy may or may not be dose-related, even though the slide tells you that it is dose-related. That's still something of a controversy. And the point of this slide here, which demonstrates that for most of our patients with distal ulcerative colitis, that actually while rectal therapy alone is terrific, and that's in orange, it's actually the combined therapy in an intention to treat manner that really is so much more successful. And so we always double cover our patients, or make the attempt to double cover our patients early on with both oral and rectal therapy. And these agents are all quite terrific at the maintenance of remission, and there you see some of them with branded names, and I know that's never kosher at a meeting like this, but suffice it to say that the point of this slide is that they all work about the same, though again, no one has yet to knock sulfasalazine off its perch over the short term. It's the long-term development of toxicity that make people suspect that in an intention to treat manner that it'll break down. And this is the big bugaboo, and this is why we fail too often, why our patients seem to have more flares than we'd like them to, particularly when they're in maintenance, and that's because they're non-adherent. Patients who are adherent stay in a remission for very long periods of time, and as you can see in Susie Kane's study out here, adherent patients out at 3 years really have remarkably high rates of maintaining that remission and not having intercurrent flares. The non-adherent patients, however, don't do so well. So the medicine works, but you got to take it. And it's really difficult to convince 20 and 30-year-olds to be adherent to their medications. I actually show them this figure sometimes in the office as a way of demonstrating to them the benefits of becoming adherent to their medications if they're not. There are all sorts of other things that can be done as well. Many of these medicines that we give in the mesalamine class are given TID, some even QID. That's just too much, and based on what we know about colonic motility, I think it's fine to separate these patients into BID dosing around the times that they brush their teeth. Hopefully they're brushing their teeth. We all care as a society way more about dental caries than most anything else. And if you can convince them to just take a few pills when they brush their teeth, they're much more likely to do better. There is now, however, a once-a-day dosing medicine that's out there. Whether it is as good at maintaining remission or not remains to be seen. But these medicines, as good as they are, the mesalamine-based agents or the immunosalicylates, they do fail, and they don't seem to work very well for our moderate and severely active patients. So we have to have other things that are out there, in addition to you guys, always at the tip of the pyramid, surgeons. What we need to do is really step up our therapy when it's appropriate. It's a big controversy when you bring in the more heavy-handed medications with a less clean side effect profile, certainly than the mesalamine-based agents. But this is sort of how we like to view things. We start with the mesalamine-based agents early, and for our patients who break through, there is still corticosteroid use in these patients, though only for the induction of remission. There are no good data for their maintenance of remission, and we will, depending on whether you have an early adaptive gastroenterologist that you work with or not, we may bring in azathioprine or 6-MP with the very first administration of a dose of corticosteroids as a maintenance medication, and then more recently the use of infliximab, one of the biologic anti-TNF-alpha antibodies that's out there, and the only one I think that has an indication for ulcerative colitis, and that's fairly recent also. When to bring that in is still a huge question, if not a controversy in what we do. So the steroid literature here, and I always, unfortunately Bill Fabian has left for the airport, but this is some excellent work that he did at the Mayo Clinic that demonstrated that for our patients with ulcerative colitis, most of them do get an immediate or early response, get their remission induced, but what you find out is that after a year of using steroids, a much larger percentage of patients than you would really like either still go on to surgery or develop an element of steroid dependence. And so it's important to recall that for our patients who need corticosteroids to induce a remission, that there is that potential for steroid dependency, that these are a high-risk group of patients. They're much more likely to go on to surgery, and that these medications in and of themselves are awful, truly awful for maintaining remissions. They've never been shown to work and the myriad side effects and adverse events that go along with corticosteroids really makes us all hesitant to use them. I think that's an evolving position that has really come into being over the last 20 or so years, and I think that we're all doing a much better job now of limiting exposure to corticosteroids. And interestingly, that in and of itself has become an outcome measure in so many studies, not only of ulcerative colitis, but of Crohn's disease as well. And it's quite apparent that the more steroid you get exposed to, the worse off that you are. So in terms of maintaining remission in ulcerative colitis as opposed to inducing that remission, the mesalamine-based agents really terrific, but really only for those mild and some moderate disease patients. And we really need to reach for azathioprine and 6-MP for our more severely involved patients, particularly those who require some corticosteroids. The evidence that supports azathioprine and 6-mercaptopurine is not as ideal as we'd like it to be. These agents have long ago lost their patents. It's very difficult for us to find pharmaceutical company money to support such studies, but such studies do exist that are out there, and these are the results of one of them from the British Medical Journal not too long ago, really demonstrating a numerical benefit, even though statistical significance wasn't reached here, but albeit in a very small study for azathioprine in terms of maintaining that remission. And clearly, these medications are terrific. Excuse me. At demonstrating a steroid-sparing effect, which I think is truly an appropriate outcome measure. And so we use this a lot, but it's still controversial. And in fact, in Japan, you can't get the National Health Service there to pay for azathioprine or 6-MP in terms of maintenance of remission. And that's a small point that I'll get to in a later slide with later commentary. These medications, as opposed to the mesalamine-based agents, they don't come free. And in fact, they have about overall a between 15 and 20% rate of toxicity. The main ones that we deal with on a day-to-day basis are bone marrow toxicity, particularly with leukopenia, though any of the counts can get decreased. Pancreatitis, which occurs early and is sort of largely hypersensitivity mediated. Hepatotoxicity over time, and so the bone marrow toxicity and the hepatotoxicity are why we have to monitor these patients with regular blood tests. GI intolerance I've never found to be an issue. Fevers and arthralgias, these happen early. The diarrhea, again, not particularly an issue. Unclear whether there are truly an increased number of infectious complications on these agents. We actually have a study ongoing now to see if ordinary variables associated with high infectious risk, both in vitro and in the human body, are increased in these patients. So we don't really have an answer for that yet. There is a theoretic increased risk of lymphoma and other blood-related malignancies with these patients. That takes up the bulk of the discussion in discussing risks and benefits when we start these patients on these agents. I believe that risk, based on a meta-analysis by Jim Lewis and colleagues, to be about 3 times the usual rate, but we're talking about the baseline population really having a very low rate of lymphomas, and so the size of a study needed to be done to truly determine what that rate is going to be a long time coming, and we're not there yet. So I tell patients about a 2 to 3 times rate. In addition to the purine analog immunomodulators, what we also now use is infliximab. And the clinical response rate for infliximab in the treatment of ulcerative colitis are really quite impressive relative to placebo. These are patients with moderate disease activity receiving induction doses at 0, 2, and 6 weeks, which is our usual regimen in Crohn's disease as well. And as you can see, by the time they get to week 8, almost 2/3 of the patients receiving active therapy will have had a clinical response. And then if you follow them out a little further and they're not getting repeated dosing, you see that response starts to wane, although they're still doing better than the placebo group. And so these agents clearly are effective in the treatment of moderate disease. Whether they're effective in the treatment of severe disease is also an unanswered question. And it's remission that we really care about, not so much response. And you can see again that remission, certainly this agent is better than placebo. And there is a reasonable duration of that remission out at a year. And so important to keep that in mind, that this is something that is up our sleeve. But of course, this agent too, which is a part murine antibody, it's about 85% human and 15% murine, does come at a cost. There is certainly an increased risk of infections that have been demonstrated with the use of infliximab across the board, and not only in ulcerative colitis, but in Crohn's disease, rheumatoid arthritis, psoriatic arthritis, and now psoriasis as well. And there have been more than a handful of cases of fatal tuberculosis in treatment here. And so we have to make sure that our patients are PPD negative. If there's uncertainty about prior exposure, or if they're on corticosteroids and you don't trust your PPD test, you need to get chest x-rays in all these patients. There's theoretic increased risk of malignancies, and there certainly have been now 13 of very, very uncommon forms of lymphomas in these patients, gamma delta T-cell lymphomas. All of those patients were on 6-MP or azathioprine in addition to being on infliximab, and so it hasn't been teased out what the individual contribution of this antibody is. There are a number of different contraindications to treatment with infliximab. Hepatitis B reactivity is up there as one of those. There are rare forms and more idiosyncratic forms of hepatotoxicity, hematologic events as well, with significant cytopenias and hypersensitivity to this as well, though it's not a true allergic mediated reaction, and these patients are just getting a part mouse antibody, and not surprisingly over time they will develop antibodies, their own antibodies, presumably against the mouse portion of it. And there are also interesting and unusual neurologic events that can happen with a multiple sclerosis-like picture being the most common and most feared, though most of those do resolve with cessation of therapy. I have had the good fortune of that only happening in one patient of mine, of course an attorney, and she thankfully resolved. So, finally, with just a couple slides to go here, the important points is that we have to get a remission. If we don't get a remission, we need to go on to sort of more desperate, at least us gastroenterologists, more desperate measures of IV cyclosporin or surgery. And once in a remission, we need to do our best with the medicines I've told you about to maintain that remission. So cyclosporin is sort of a more novel therapy borrowed from our transplant patients, much as 6-MP and azathioprine were as well. And in this study that was done out of Mount Sinai, my institution, Dr. Salke's institution as well, 82% of patients of a group of 20-odd patients were able to get into a remission or a response that enabled them to avert surgery. And this is a terrifically useful medicine that, again, because its patent expired so long ago, it's very difficult for us to get out there and advocate its use. It really should only be used at institutions where you can measure cyclosporin levels. Has to be given intravenously over time, but it's a marvelous, marvelous drug for patients with severe ulcerative colitis, and the only one that has a meaningful track record in its use. This study was actually stopped prematurely because of that outstanding difference in response rates between patients actively treated and patients who were given placebo. And these were all patients who failed IV corticosteroids. They were all on IV corticosteroids when they started. Cyclosporin doesn't come free either. Nephrotoxicity, infectious risks, seizures, and other neurologic-related abnormalities are the big ones that we worry about. We follow creatinines. We determine how shaky their hands are, and we make sure that they have adequate cholesterol levels and magnesium levels when we give it. So there are also emerging therapies and a few questions that are still out there for the treatment of ulcerative colitis. Newer kid on the block that may be coming down the line is visalizumab, an anti-CD3 antibody that's out there. Whether infliximab has a role similar or somehow different to cyclosporin in severe disease, and tacrolimus, another calcineurin inhibitor not dissimilar from cyclosporin, which can be given orally and was demonstrated to be of benefit in a study out of Japan about a year ago when they couldn't give 6-MP to their patients, as I had mentioned. And so the role of infliximab is still in question. Whether these medications, any of these medications, may or may not be chemopreventive in terms of averting cancer risk is still an issue in question. I think that the data are still a little too weak to make a carte blanche recommendation there. But those are issues going forth in medical therapy, and hopefully you'll have close relationships with your gastroenterologists, and everybody knows the options that are out there. And I thank you for your time. I've already gone overboard by a minute, and I apologize, but thanks very much.